Welcome. I am your author and presenter, Dr. Forrester Dean. I've been keeping South Bay healthy since 2006 here in the LA area. I am the campus administrator and events and education organizer for Performance CXS. I'm a sports medicine and family practice chiropractor. I'm a sports medicine physiotherapist, and I operate here on property a clinical network. I'm also the author and patient advocate of Better Patient Solutions. I am a research author by heart and a blogger, and I just completed a 4-year project, Pain is Not the Only Problem, a low back pain research project, also known as PINTOP, with 43 articles, a brand new dictionary, and of course a podcast complement. I am the Correct System National Educator and Professional Certification Body. I am a USTA tennis instructor, and my motto is Safe and Friendly Play. I'm also a yoga instructor, and my yoga instruction is based on the origins of the yamas and the niyamas, and I love to teach restorative and vinyasa yoga. I am also a recreational short track and run sports coach. I am also a recreational boxing and kickbox coach. I teach nutrition and meal planning. I have a sports psychology network, and my specialty is women-specific perimenopausal health and fitness. Clinically here, I complete a thorough history and exam. I don't use the classical orthopedic exams, and I make sure to check in with the patient about any changes in psychology or their ADLs. 3 of my classic statements are, how do your symptoms make you feel? How can I help you today? And what are your expectations of me? I also make sure that I do complete chart notes, including incidental findings. I do a complete diagnosis on the very first visit, and my diagnosis is usually 4 to 10 different diagnoses, and I make sure that I include anything from their problem list. I provide patient education and definitely homework. My motto is to treat in 1 to 4 visits maximum, and I'm always searching for the lowest possible cost. And what I mean by is for the term of that specific complaint. Subthreshold microtrauma presentation focus. Number 1, reevaluate the prevailing clinical practices thought to manage clinical pain. Number 2, submit and debate novel pain contributors and mechanisms. Number 3, meet patient expectations and satisfaction and clinically meaningful results. And number 4, recommend a conservative non-surgical course of care to override pain instantly. And number 5, restore ADLs and patient confidence on the first visit at low cost. Most commonly, a patient will describe their injury or complaint in relationship to a specific event, a movement, a reach, or unexpected move. Clinicians tend to look for a time-stamped event in which to describe and understand the patient's complaint, or tend to blame degenerative changes as interpreted in plain films and advanced imaging. I will argue in favor of a different description that will offer a different understanding, since it compels the patient and the doctor to move rapidly forward with a diagnosis and course of care on the same day and at low cost. Since my practice and curiosity are focused on hastening recovery at low cost, I have invested over 1,200 hours researching the highest quality evidence available to meet my clinical goals. As a result, I am able to provide same-day solutions for simple complaints of episodic pain and treat failed back surgery and conditions such as frozen shoulder in 1 office visit. Since clinicians tend to pride themselves on their knowledge of the human body, I thought it would be fun to give you a Genius Physicians quiz. These are 7 questions that people have a lot of trouble coming up with the answers for, so I thought I would just toss it into the presentation and we can look at the answers later. Where does the cranial nerve 10 have a dermal stimulatory location? Where is the spinal cord observable with a non-invasive plain sight location? Which cranial nerve interprets hip position? Which cranial nerve or nerves interpret talar dome position? Can the spinal cord feel pain? And if it can, how? Does the brain prioritize function over pain or pain over function? And which afferent signal does the brain listen to first or most? And the hint is that it's 100 times greater than the pain signal. Since we're going to be discussing trauma, I thought it would be important to first help frame our understanding of pain. These are some quotes from some prior work that I did. Pain results from the activation of a subset of sensory neurons termed nociceptors and has evolved as a detect and defend mechanism. However, lesion and disease in the sensory system can result in pain that serves no protective function. That's from Smith, 2018, who also offers us this. Nociception is the neural process of encoding noxious stimuli, whereas pain is defined as an unpleasant sensory and emotional experience. And then we have Brodall, 2017, who offers us this. We must distinguish between the experience of pain and the meaning that the person gives to it. The person's beliefs about the cause of the pain may be right or wrong. And then from Punjabi, 2006, the exact cause of most low back pain remains unproven. And then finally, Salto et al., 2018, phantom limb pain is associated with neither a damaged tissue area nor an inflamed part of the body. It's important for us to agree on the objective or subjective realm of pain before we talk about the rest of the presentation. Reevaluating pain. Can an afferent signal arrive at the brain that is only dedicated for pain? Is there a part of the brain that detects and processes pain? Are there neurons that are pain-specific, pain-selective? Can you think of any other areas of the brain that might light up along with pain? Let's consider these 7. Attention. What we mean is recognition or behavior modification or a display of unpleasantness. Fear processing. Current or possible bodily harm. Sympathetic response. Body heat, pupillary changes, agitation, tension, and tone associated with muscles, motor mapping, defense, antalgic behaviors or postures, guarding or apprehension, memory, injury association to history of self or of others, daily planning, social changes, and self-care injury association, and emotion, empathy, frustration, worry, catastrophizing, anger, tragedy, or loss. What is the definition of pain? Besides injury, a patient may experience pain when the patient moves suddenly, when the patient moves with novelty, when the patient moves into a broader active range of motion, when the patient moves without a preset, meaning that their core is not activated, when the patient moves without confidence, when the patient moves with anticipation or fear, when the patient moves with the expectation of pain, or when the patient is already weak and when the patient does not have movement history. So you'll notice that the common denominators here that define pain are correlated with the word move or moves. I found this article from Yam et al. 2018, and I like these 2 quotes. A concept of sensation that we feel as a reaction to the stimulus of our surrounding, putting us in harm's way and reacting as a form of defense mechanism that our body has permanently installed into its system. The sole purpose of notifying the body's defense mechanism to react towards a stimulus in order to avoid further tissue damage, to detect pain and produce a response towards that threat. Dean 2016 describes pain in this way. Pain is a story, an idea, an interpretation. Pain can't be objectively demonstrated. When the clinician touches the area of the patient's complaint, the patient says, ouch, but the origin of the pain is never located at the diagnostic touch site. The origin of pain is located in the brain, an experience interpreted by several factors related to the touch site. Pain does not originate nor occur at the injury. A signal is generated at the touch site called signal X and can have many origins other than true nociceptive triggering. Dean also says this: the pain signal is exposed to a wide variety of influences and is never an exact or predictable or reproducible representation or presence of genuine or patient-imagined tissue damage and can never be seen or diagnosed from a picture. The International Association for the Study of Pain in 2020 updated their definition. Their definition of pain is An unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Dean 2016 defines pain in this way: afferent signaling interpreted by central processing that recognizes the existence of potential, real, or imagined tissue damage. If we color code Dean's definition of pain, we can break it down in this way and understand it a little better. First, we're talking about afferent signaling. This is the nervous arousal pathway that communicates from the body to the brain. Interpreted by central processing, the experience conjured with cognition. This means that the brain is listening for these signals and is trying to interpret them. That recognizes the existence. Well, there's of course a reflex, a response, and a realness to this signal. Of potential tissue damage, meaning the brain is predicting or postulating sources, but there may be no evidence. This is an example of dull or achy pain. Of real tissue damage, we're of course talking about evident injury sources, like a fractured bone, bleeding, torn skin, these kind of things. And then of imagined tissue damage, of no known source, and an example here is phantom limb syndrome. We need to understand what pain is and isn't clinically. There are no orthopedic exams to demonstrate pain, only to demonstrate injury. There are no labs, tests, imaging, or diagnostic studies to demonstrate pain. Suspected or real injury does not always demonstrate pain. Pain can't be measured or reported on a scale. Descriptive pain does not correlate to the qualities of the injury. For example, sharp, shooting, dull, achy, annoying, stress, tight. Pain does not occur anywhere in the musculoskeletal system. It occurs only in the brain. The pain signal has the lowest afferent prioritization, and there is no diagnosis called pain. For more information about afferent signaling, you can go to my Pain is Not the Only Problem blog and look for articles 10, 11, and 16. Now let's look at the 10 afferent signal categories. Remember, afferent just means everything that the brain's paying attention to. All the signaling that's arriving in the brain, trying to tell the brain what's going on in the body. The first category is called Noxious Stimuli, so this is not pain. The first 6 are called Ergo Receptors, and these are very low threshold. It means that they are easily listened to in the body. The first one is Mechanoreceptors, which are reporting on muscle acceleration, deceleration, muscle tension, vibration, and gamma gain. The next is Proprioception, which is reporting on the 3D spatial self of the body. The third is Chemoreceptors, are reporting on, for example, delayed onset muscle soreness, other muscle soreness, and arterial CO2. Osmoreceptors are reporting on osmotic pressure. Baroreceptors are reporting on changes in blood volume. And then 6 are the Enviroceptors, which are reporting on intake of vision, sound, taste, smell, the cranial nerves. The next category is called Metaboreceptors. These are reporting on muscle work, which includes momentary strain. It's also reporting on muscle contraction and feel, sometimes interpreted as muscle pump. The next category is the metaboreflexors. These include metabolites that are required for work and reports on force production and shutoff timing. When should the muscle start and when should it stop? And then there are Enteroceptors. These are reporting on touch, pressure, internal and external, vibration, temperature, and friction. The next category is Noxious Stimuli, also known as tissue salvaging. These are also known as the Nociceptors, which is different than pain. Nociceptors report the signal. Pain is the experience that is interpreted within the brain. Nociceptors have a very high threshold. That means that they are reported on after the 9 categories above on the slide. These are slow signals, and they report on heat and cold risk range. Is the hot too hot? Is the cold too cold in order to salvage tissue? Is the deep pressure intractable? so much pressure that it is going to cause the gut to cut. Psychological expectation and fear avoidance and pain history are also included with nociception. This is evident with guarding and antalgias. And then finally, nociception of no possible cause, and the best example is phantom limb pain. Let's look at some contributing factors to musculoskeletal pain. This is the topic of the video. Subthreshold microtrauma, the first encounter. First, investigate repetitive joint motion pathology. Investigate the entire chain or horseshoe. The horseshoe includes the feet, the legs, and the hips. Investigate for super small ranges of motion in the FROM or functional range of motion. Sometimes these occur in occupational requirements or personal bias. Here are 4 examples. A 16-inch stride length using an elliptical machine, which includes no hip flexion, or a 12-inch hip circle using a spinning bike, which has no hip abduction, or walking the dog for cardio activity when there's no VO2 max experienced by the patient, or key typing on an 18-inch monitor, which limits eye and arm active range of motion. Also investigate absent complementary joint active ranges of motion. For example, on a treadmill, there is very little contribution of the hamstring, mostly of the quads and the glutes. Also investigate why the patient is pushing through pain. And then look at chronicity. What % of the day part of the patient's life is not experiencing options? Modal history. Is it monomodal or multimodal? This means, is the patient's life limited or are they getting a lot of variety? Can they provide self-stability or is it being forced on them by the position of a chair? And then there's planar history. Is their life stuck in the sagittal plane or are they getting coronal and transverse plane also? Is there planar duplication and repetition? For example, sitting in a chair and then exercising on a treadmill and then going home and sitting on the couch. That's multiplied sagittal plane with no coronal plane and no transverse plane. And then we're also talking about absent planes of motion. This is the arrow plane, sagittality, always moving forward, never sideways, backwards, or twisting. And then investigate lifetime history of motor patterns, their exercise, activity, occupational, and leisure. And what we're looking for here is not traumas and not injury, but we're looking for biases or common overlaps in how the patient uses their body. For example, is the way they exercise very similar to leisure? And is that similar to the way they use their body at work? What would happen if the patient walked versus hiked versus bike? A bike certainly requires more balance than walking. Why do they avoid balance activities? Or maybe they prefer cardio or classes versus something that's more strenuous or more challenging. What we're looking for here in the lifetime history of motor patterns is to discover the repetitive commonalities in how the patient uses their body. For example, their leisure activities, those planes of motion, may overlap a lot with occupational ranges of motion. And then let's look at the progression and changes over time, or reversions to prior uses of the body, or total chronic changes. So for example, a patient that's a landscaper for 12 years, which requires a lot of squatting, bending, and picking up of heavy loads, and then becomes a fitness trainer, where there's multiple planes of motion, more planes of motion than in landscaping, and then becomes a student for 6 years, which is primarily sitting, sagittal plane, and missing the multiplanar ranges of motion. And then after graduating, goes back to being a trainer, where there are those multiple planes of motion. That's an example of reversions. And again, what we're looking for here when we're discussing subthreshold microtraumas are not specific incidences of injury or trauma. We're looking at repetitive traumas in very small ways that are hidden or disguised in the lifetime history of their motor patterns. And then, of course, look at the patient's purpose for how they use their body. Does it determine overall equity? For example, a patient that's running to lose weight. Are there other ways to lose weight? Well, of course they are. But the running pushes them into the sagittal plane and eliminates the other planes of motion. This is a perfect example for the setup of a subthreshold microtrauma. Also, the patient's deficits. Positional deficits. What are the positions that they avoid? Do they stretch? If they don't stretch, why don't they stretch? This is a perfect example for a setup of a subthreshold microtrauma. What about the patient's emotionality, their hesitations, their avoidance that limits planes of motion? This is a perfect setup for a subthreshold microtrauma. And then finally, the patient's diagnostics, their current condition, interpretations on their condition, and their prognosis. This is very important to understanding their subthreshold microtrauma prognosis. The most common examples of musculoskeletal pain are due to these four factors. 1. Habitual movement patterns, small or restricted, almost imperceptible, and almost always require core recruitment. 2. Limited active range of motion without complement ranges of motion. 3. Movement deficits that are chronic, commonly associated with occupation, of modal and planar limitations. And 4. Self-described emotionalities, fears, hesitations, and avoidance. These four factors not only are examples of musculoskeletal pain contributors, but are also the perfect setup for subthreshold microtraumas. So then we can conclude that musculoskeletal pain is less about a single event-based incident, also known as what happened, and more about these small restrictions, these small limitations, these small hesitations about what doesn't happen. This is the setup for subthreshold microtraumas. I saw this kid at the bakery on his phone. This kid must be like 6'5". The point of the picture, though, is this patient might have a disc herniation, and you might see that on MRI, but is that the cause for his low back pain? So the MRI is not going to demonstrate how this kid likes to hang out in a chair with his phone. But you can see clearly that this is not going to promote spine health. This is a perfect example for a setup for subthreshold microtrauma. Let's look at the common model for the patient's first encounter in course of care. Patient comes in, patient intake, they talk about their complaint, their limitations, and then of course the doctor wants to treat the symptoms. In my office, I take a bit of a diversion. First, I try to understand the processing afferents. This is mostly proprioception, and I call this the continuum of mechanisms. Information that's taken up from the body to the brain's interpretation of these, and then the outputs back to the body, either for action, mobility, or they may be interpreted as a symptom. There's, of course, with symptoms, lifestyle coping, fear, compensation, antalgias, or quality of life changes, right? There's pain, there's problems, there's limited range of motion. Then we get to patient diagnosis and education. This is what I call diagnostic relief. The patient understands what's wrong and why. And then the patient receives their instructions for their care and all the contributors to the healing. Next comes the best part. The patient's instructions and contributions to healing provides CNS receptivity. The brain understands, it makes sense. The patient's excited. They start to feel a little better. They have ambition. They experience reduced input stressors. The body understands what the problem is and why, and the patient is modifying their lifestyle away from those stressors. Then with the treatment, there is afferent distraction and novel movement. More progress is made as plastic, reactive, and distributive changes occur. The patient's even more excited. And then there's improved tissue health and healing stressors, and this is of course related to membrane potentials. But what happens when the care plan is reductionist? and based completely on pain management. It's the wrong treatment because it doesn't address the problem, it only addresses the symptoms. This leads to flare-up, patient disappointment, patient noncompliance and suspicion, driving up costs and delaying healing. The treatment plan is questioned and then changed, and then wind-up occurs, reactivation of symptoms, depression, and chronicity due to healing failures. With the reductionist approach and a focus only on symptoms, specifically pain, the entire course of care fails. The patient's intake is a focus of pain and not on processing afferents. Lifestyle coping is ignored. Patient diagnosis and education is ignored, and there's no diagnostic relief. This leads again to patient noncompliance and suspicion, flare-up, disappointment. The treatment plan is questioned, and wind-up occurs again with chronicity due to healing failures. So far, it has been important to discuss the various definitions of pain, the various causes for musculoskeletal pain, and that circular model to build a reference point for the subthreshold microtrauma model. They are very, very different. It is a completely different approach. Subthreshold microtrauma, as defined by Dean 2016, describes 1. Subclinical soft tissue injuries. We're talking about voltage-gated tissues, muscle, fat, fascia, lymph, arteries, veins, nerves. And 2. Subclinical hard tissue injuries, collagen-based tissues, bone, ligaments, tendon, cartilage, implying that the patient is asymptomatic, and 3, not seeking care and is likely due to an abnormal movement pattern, or also called a faulty movement pattern, and 4 is associated with a symptomatic area of tissue, but not always at the symptomatic area. These 4 different components are key to understanding the subthreshold microtrauma clinical model. To understand the subthreshold microtrauma clinical model, we need to understand the definitions of subthreshold and microtrauma. Subthreshold implies subclinical tissue damage that does not have the attention of the patient athlete. They have not sought care because there are no presenting symptoms that are annoying enough to cause intervention. The patient athlete might notice minor changes in performance and brush them aside as episodic. Microtrauma implies non-traumatic incidental tissue damage that does not evolve into the acute phase of healing. There is no noticeable soreness, redness, inflammation, or tenderness. However, there is enough tissue damage to cause motor efficiency to change, such as strength, time under tension, plyometrics, loadability, load, total recruitment, mobility, active range of motion, stability, capsular stress thresholds, precision, or what we say quality and consistency of movement, innervation, metabolic delivery and waste removal, and modality, for example. This is the basic schematic to describe subthreshold microtrauma and most common management of musculoskeletal pain. On the left, you will see there is the VAS scale from 1 to 10, which is going to describe pain. And the bottom, you can see that there's time, hours, days, months, of repetitive subthreshold microtrauma insults, also known as movement faults. The chart is divided into the red zone and the green zone. The red zone describes clinical threshold for intervention. The patient is symptomatic and asking for a call to action or seeking treatment. The green zone is subclinical. This is subthreshold traumas. The patient is asymptomatic and has no complaints. Now we add the graph of incidences of subclinical tissue damage with repeated attempts at healing. The example here is a bad tennis forehand because the patient is trying to swing with an outstretched arm. This is also known as a movement fault. The red arrows indicate occurrences of tissue damage with improper swing over time, less ability to heal, but still subclinical. The green arrows indicate attempts at healing that are less successful with time. Notice that the green arrows get smaller. Let's look at this expanded view of one traumatic event, let's say a day on the tennis court. The red arrow indicates a faulty movement pattern. The patient is swinging her forehands over and over, let's say for an hour on the court, and this is creating some tissue damage because she has a faulty motor pattern. The green arrow indicates the natural phases of healing. This is the time after she leaves the court where the phases of healing occurs to try to evolve some tissue repair. But then you'll notice the second red arrow, she goes back to the court a few days later with her faulty swing and creates more tissue damage. Let's look at this graph charting these traumas. Looks like the patient has 8 red arrows. So in this example, let's say she's been to the court 8 times over 24 days, about 3 days in between each time. So this allows for a certain amount of healing to happen, which are the green arrows. But you'll notice over time that the red arrows more and more approach that horizontal line between the red area and the green area. And you'll notice that over time, the green arrows are not able to bring full tissue repair. In fact, it has diminishing results in tissue repair, hence the smaller and smaller green arrows. Then look at this area here where there's a white circle. This is the threshold for clinical intervention. This is when the patient seeks care because they have pain. Remember, in the green zone, this is subclinical, subthreshold. The patient is asymptomatic and has no patient complaints. The red area is the clinical threshold for intervention. The patient becomes symptomatic and has a call to action for care. When function is undiagnosed and uncorrected and the clinician focuses only on resolution of symptoms, all function occurs now in the red zone. This means that this patient is continuing to go back to the court. Looks like she's been there 3 more times over the course of several days, and she's trying to play on an injured arm, maybe with some palliative care. But I want you to notice that there's no tissue healing, right? The green arrows are gone in the red zone. Let's look at how the patient's situation has changed. The red arrows have become yellow, and the green arrows have become blue. The yellow arrows indicate increasing patient symptoms that require clinical intervention. The blue arrows indicate increasing failure to treat that require clinical intervention. So this patient is trapped now, out of function, and in the red zone. This chart represents multiple doctor's office visits without faulty motor pattern diagnosis and continued care that's focused only on pain. This is delaying the patient's ability to get back to the tennis court. Her care is becoming expensive and it's being delayed. Okay, now I want to talk about some of the details in the chart that we've already looked at, okay? So just quickly, we were talking about, this is sort of that VAS scale. So we're talking about, perceived pain, right? But in this example, we're not talking about pain specifically. We're talking about injury, right? Yeah. So that the VAS scale is going up. And then over here on this scale, we have time. And remember, we're talking about any number of increments of time, but we're not talking about like an injury, a small injury just today. We're talking about imperceptible injuries, little injuries over time. So in my example, I talk about tennis a lot, right? So we're talking about someone who's swinging for an hour during their class, and then they have another class or 2 more in the week, and they go back. And this has been going on maybe for about 6 weeks. And they start to feel a little irritation somewhere, but it isn't enough irritation to ask them to go to the doctor. They may have been putting ice on it themselves, or maybe they didn't, right? So what happens is and this is totally random. I'm just gonna call this green line here. That's the clinical threshold. So that's when the patient seeks care, right? So what's happening is, and I'm just gonna make a chart out of this. So let's say, the patient has no symptoms of any kind, so they're here. Now, the patient goes and they play tennis on this day, and it creates like a little irritation, right? But it doesn't catch their attention. It just happens, right? And then the body naturally heals it back down, right? So she's kind of back where she started. But then she plays tennis again, and there's just something wrong with her swing, but she doesn't know it. Coach hasn't seen it, her tennis mates, they don't see it, right? Maybe they're all kind of doing this kind of a modified swing. So she goes back and then it happens again, right? And she doesn't, it just keeps happening over time. So let's just say this is that, that 6 weeks period. But now she gets the same injury, and remember, she doesn't know it. She just understands it as maybe a limit in her range of motion. Maybe she's not extending her arm all the way because it's uncomfortable. It doesn't always have to be about pain, okay? And now look, it's a little bit higher than it was here. There's a little bit more injury, but she still hasn't sought care yet. So this kind of goes on. And each time the body heals it, right? So the body's healing, she gets re-injured, the body heals it. But you'll notice now over time, the body is less and less and less healing it because the occurrence of that injury, right? It's happening so often, she's missing the phases of healing, right? So clinically, what do you understand about, as an athlete, like what do you understand about, oh, I continue to do the same thing, but I'm not paying, I know there's something wrong, but I'm just gonna kind of ignore it and I'm gonna keep training. So this little piece of that graph, what does that mean to you?
Specifically, what that would look like to me is pushing through, so say for instance, it affected my functionality. So now I have to compensate. So whatever I'm doing to compensate might end up being a faulty motor pattern or movement pattern. And from there, it's going to keep re-injuring it, calm down. Now I have to make another adjustment. So these are adjustments that I have to make. So every time I make an adjustment, it makes the situation worse because now I'm not as stable as I should be, which then that leads to other issues, leading to like a possible injury, or in this case, re-injuring it and not healing properly. So now it's a buildup of scar tissue that's happening.
And that's a good point. So we're not just talking about this one injury, but we're talking about injuries starting to accumulate on top of each other.
Exactly.
So it isn't just this injury, it's also this injury, and it's also this injury. And these injuries, you're saying, right, they're sort of topping out. They're kind of, it's like the original injury, but now a compensation faulty motor pattern, and that's causing another faulty motor pattern.
Exactly.
And she's trying to play tennis with all of this going on, but she doesn't know it yet because she hasn't seen anybody and it hasn't been diagnosed, and she's not really paying attention to it. But then what happens one day is it starts to approach this seeking care. So we call this, right?
Clinical threshold.
That, yes, clinical threshold, right? And she starts to oscillate just below that threshold. And the body is not able to repair. So she's playing tennis, like we all know this, you're playing on an injury, right? But then one day, it crosses that line. For some reason, now we could say, via, visual analog scale, we could say pain, right there, right? But we could also say, I can't take it anymore. Right? Like
complete loss of functionality
right. And I think that's a better way of explaining it, as a complete loss of functionality when you're prevented from doing your sport now. And of course, now there are emotional issues, and now she doesn't get to hang out with her friends, right? So that whole annoying thing that starts to happen. So what happens is now she's crossed over the line, So we call all of this action here subclinical, sub-threshold. The threshold for clinical intervention hasn't been met. But look at all of these instances of injury that have been unidentified, even by the player, by their coach, by their teammates. But they haven't gone to see the doctor, they haven't asked for any sort of support, not even really like gone online and looked at the internet, right?
Yeah.
So what happens is, once we get over this clinical threshold, she's now in the care, right? She's now in like this care zone. And so what I want to ask you is, what do you think? Do you think that her care zone is going to address this pain and symptoms? Or do you think her care zone is going to address the faulty movement pattern history?
In the care zone, in the traditional
Clinical care zone.
So in a traditional model, it would only focus on like pain. So they would focus mostly on pain and dealing with the symptoms of whatever just happened, especially if she had tense elbow or something like that. What we look and how we look at things in the clinical aspect is we want to address that faulty motor pattern.
Down here.
Yes, because if you address it down here,
you don't ever cross the line. Right? Can you grab the, I think it's down actually at the bottom, the eraser? Yeah. So then what we're going to do is we're just going to kind of leave this all here. Right? And now what we're going to do is we're just going to represent all this zigzag. I'm just going to zigzag it over here. Right? And then that's crossing the line. So what happens is now she's in that classical care, right? And what happens is she also starts to get this, right? So the because this is the symptom zone here, right? This is symptom zone, and this is the faulty motor pattern zone is here, right? Symptom zone, faulty motor pattern zone. So she's getting, let's say she's getting some medication, right? She's getting some medication, but she's still in this zone where she needs care. The requirement for care is ongoing because this didn't get addressed.
And right in here, right when she's in the care zone, and another reason why it's a big deal is because even with the medicine, the care, the treatment, the modalities, ice, heat, everything to bring down that inflammation and originally, if we don't address that as soon as possible, it's going to spike again, and she's going to stay on a kind of a horizontal cue to stay in just getting care, which is going to affect her motor patterns, her sport, and then it's going to lead to a failed outcome, which then leads to depression. It can lead to depression and frustration from not being able to participate with her friends.
So when they're in this care zone, you know, we'll just say commonly, but not, of course, not all the time. This is where her tennis is. Tennis is in this zone. So if her care plan keeps her in the care zone, even though she's, you know, getting some palliative care, you know, she feels better, she still can't play tennis.
And it's actually affecting whatever skill set she was at because of the lack of being out there to hone her skills. So now that's going to have a diminished effect.
Right. So the point of kind of going through this as an interaction, because we're both athletes, and sometimes, you know, it's easier to hear it sort of in a dialogue. But the point we're trying to make is that yes, the care zone is good, but classically the care zone never brings the patient back into performance because it's only addressing symptoms in the symptom zone, and care in the symptom zone doesn't transfer to care in the faulty motor pattern zone or where she is playing tennis.
Yes.
Yeah. So I hope that explanation was a little more helpful, and then just go ahead and continue with the presentation and we'll talk more about that. With time and an improper or incomplete diagnosis and the wrong treatment plan, tissue repair becomes absent and injury becomes chronic. The patient has to stop playing tennis now. Let's look at the indicators for clinical care management problems in this case. Patient's ADLs and desire to return to play were not considered, and this is likely because she didn't receive a report of findings. Her functional diagnosis is absent. She just received a diagnosis of symptoms. She didn't receive a tissue repair treatment plan. She received care that's based just on pain and on symptoms. Of course, this increased the patient's cost and delayed her healing. And so the patient is going to experience what's called failure of conservative care, which means that she didn't get a chance to experience a function-based treatment plan or diagnosis. And so what happens is this patient gets sort of shuffled over into the surgical medical intervention model for pain. It's just a focus on pain only. The patient's situation has gotten even worse. Tissue repair is completely absent and her injury becomes chronic. This means that the patient has to stop playing tennis altogether and is not part of her patient values. This patient wants to get back onto the court as quickly as possible, but a focus of symptomatic resolution and a course of care that's based only on symptoms, specifically pain, is never going to get this patient back on the court. Without a diagnosis that's focused on the faulty motor pattern and only paying attention to symptoms, this patient now has become beyond tolerable limits. She's not enjoying her life. Sports activities are impossible. Certainly she's not playing tennis. She has ADL and work disabilities, and the patient now loses trust with their care provider. Remember, she is in this chronic stage now where tissue repair is absent or maybe even impossible at this point. The patient is beyond their tolerable limits. She can't play tennis. Her ADLs are limited. She's lost trust in her care. She's received the wrong treatment with a focus only on pain. She becomes highly emotional. She gets sympathetically dialed up, known as sympathetic atonia. And the only thing that's left for her, that's offered to her, is surgery. So notice all of this text that's in red. Do you remember the circular model that was also all in red? When the patient's circular model becomes completely red, the entire course of care fails. Since the clinician insists on managing pain only and not the faulty motor pattern, the patient stays stuck in the red zone. This is where an offer of surgery is presented to the patient. But surgery never addresses the faulty motor pattern or the faulty movement lifestyle. It might address pain, or it could get worse. Surgery always creates scarring. Surgery always creates instability. Surgery delays healing and always delays her desire to get back on a court. What is the clinical solution? I will argue in favor of a different solution that will offer a different understanding, since it compels the patient and the doctor to move rapidly forward with a diagnosis and course of care on the same day at low cost. This is my recommendation. Diagnose today, start treatment today, provide patient optimism, meet patient expectations and values, and provide a course of care at low cost. Well, how do we do this? What do we focus on? If we're not going to focus on pain, what do we focus our course of care on? We focus on the faulty movement pattern. We diagnose the faulty movement pattern today. We treat the faulty movement pattern today. We provide patient optimism that the faulty movement pattern will be corrected, We meet patient expectations and values by getting our patient back on the court. And because we're not focusing on pain, the course of care can be done at a lowest possible cost. Let's update our chart and not focus on pain. Let's get rid of the red zone. Let's get rid of the patient discomfort, and let's get the patient back on the court as quickly as possible. When we zoom out, we don't treat pain. The treatment is redirected toward functional movement intervention. Pain threshold elimination occurs on the first visit. Care is directed to restoring ADLs and to RTP, return to play, and RTF, return to function. Tissue repair can begin in 24 hours. But how do we do that? Patients with musculoskeletal pain in your office actually have 5 problems: a complaint of pain, a faulty movement pattern, a second faulty movement pattern, also known as compensation, repeated failed attempts at healing, and emotionality related to unresolved pain, and this is true especially with athletes. Patients actually have 7 problems. They also have failed treatment plan. Either the clinician gave them the wrong plan, or they tried on their own to find their own plan. They never went to the doctor. Maybe they looked for internet medicine. And they have failed attempts at healing, multiple layers of unresolved tissue damage. What is the subthreshold microtrauma clinical course of care? It is reevaluation of the existing medical model in order to provide excellence in patient outcomes, also known as the R5 approach. First, recognize a true professional is operating within the parameters of their designated wheelhouse. The practice of medicine is not exempt from overstepping their ability to provide outstanding care. If you are not fully equipped to take on a patient's complete course of care, do not simply lose your patient in the vast corridors of care with endless referrals and bottomless diagnosis. Do not allow your patient to suffer from the limitations of your wheelhouse. Recognize your limitations with optimism on behalf of your patient and then move on to refrain. Doctors are obsessed with their personal ego, said the patient. Don't hesitate to resist the urge to manage patient care when you know that you do not have the knowledge to do so. Clinicians consider referral as responsible management of patient care, when in fact the referral is only kicking the can of patient care. Don't rely on random providers to incite their dogma on your patient's chances for best outcomes. Refrain from management and personally pass your patient on to a clinician that can provide everything for a speedy and cost-effective course of care, and then move on to relate. Build a network of specialty providers to improve patient outcomes. Patients want to be treated by clinicians and therapists that understand their expectations and values. Specialty providers offer conservative care, sports-sensitive care, longevity care, gender and ethnic-sensitive care, the type of care that makes the patient feel like they're in good hands, and the patient-doctor match can relate to the patient's specific complaints. Then move on to refer. Patients want a referral to someone that cares, not to someone with a vast education and no heart that happens to be in-network. When a clinician recommends a referral, it is less about passing off a patient and more about setting the patient up for the best possible care in the least amount of time at the lowest cost. Refer patients to clinicians that you know intimately, personally, and trust, and then rejoice. Did you personally monitor your patient's complete course of care? Did you check in with them regularly to make sure that their expectations were met and their values were respected? Did you personally communicate with your referrals to ensure that kind and efficient care was provided? If so, then rejoice. The purpose of the R5 approach is to give usual clinicians a chance to give excellence in care to their patients when they do not understand how to identify, diagnose, or treat a faulty motor pattern. Since they don't, the patient may get stuck in a symptom-only course of care. But there are clinicians out there that understand how to identify, how to diagnose, and how to treat faulty motor patterns. Make an alliance with these partners, and they can help you deliver the best care to your patient. Genius Physician Quiz. Number 1, where does cranial nerve 10 have a dermal or a skin stimulatory location? Well, firstly, why do we care? Well, it turns out that there's a bunch of research that's being done about stimulating cranial nerve 10. It's being done through surgery right now, but there's this other idea that pain can be dramatically reduced, the pain sensation, by stimulating cranial nerve 10. And it turns out that there's a small patch of skin on the outside of the eardrum that's innervated by cranial nerve 10. So they're starting to look at using these little teeny mini TENS unit that's on sort of an earplug that you can put into your ear, and you can wear that, and it provides an analgesic effect to the pain without using drugs or surgery. You can look up that research. It's pretty cool. Number 2, where is the spinal cord observable with a non-invasive plain sight location? So the answer is that this is the sclera, that's cranial nerve 2. The sclera of the eye is an outpatching of the spinal cord. So it's possible that we can, without doing an epidural, there's a possibility of delivering a type of chemical therapy to override or to deal with pain, accessing it through the sclera instead of through puncture. Number 3, which cervical nerve interprets hip position? Okay, so remember we're talking about a nerve, C1 to C8, that's related to the hip. So you say, well, that's impossible. Well, but it's not. So this is a really good question, and I use this one a lot. The Latissimus dorsi origin is the ilia, the crest of the ilia, and then it's attached to the arm. But it has innervation through that thoracodorsal nerve, which are the cervical levels. So remember that when the Latissimus dorsi contracts, it is definitely pulling on the hip. So it does interpret hip position. Number 4, which cranial nerve or nerves interpret talar dome position? So this one's also pretty tricky. So this is also, it's actually 2, cranial nerve 2, which is the eyes, and cranial nerve 8. And what it's doing is it's interpreting the horizon line. So when the semicircular canals in the ear combine with gaze, you get an interpretation of the horizon line, and the horizon line helps to stimulate the shift of weight on the talar dome for stability. Number 5, can the spinal cord feel pain? And if it can, how can it feel pain? Well, this is also a bit of a tricky question. It can't. So I'm confused why we're trying to do surgery to remove compression on the spinal cord. So 5, that's 5A. So 5B would be the herniation is pushing on the spinal cord. So the push has to have a force. So force equals mass times acceleration. So the disc herniation certainly has mass, but it doesn't have acceleration. So if acceleration equals 0, then mass times 0 is 0, so force is 0. So from a point of physics, it's impossible for a disc herniation to push on the spinal cord. And sadly, the spinal cord does not have nociceptors. It can't feel pain. Number 6, does the brain prioritize function over pain or pain over function? Well, this may have been evident in the presentation. It may have not. But actually, the brain prioritizes afferent signals that have to do with function much, much, much more than pain. Pain is the last priority of signaling, which leads to question number 7. Pain is listened to 100 times less than body position, joint position, muscle tone and tension and such. And so therefore, in question number 6 and 7, evolves this idea of how do we hijack pain? Well, the hijack of pain would be to prioritize afferent signaling to sort of hijack the brain with a lot of function. So this is where we get to this idea that motion is lotion. Where there's no movement, then the body has nothing to listen to. The brain has nothing to listen to, so it just listens to pain because that's all that's left. Now, what I just said is within the 43 articles that I wrote in the blog for Pain is Not the Only Problem, specifically for low back pain. And I blow that all out for you into a huge amount of detail. And I invite you to read it and look at it and enjoy it. If you want more information on my projects, you can go to YouTube to the Correct System Sports Medicine channel. We have a lot of therapy and theory videos there. You can go to my website, my blog, Pain is Not the Only Problem. I have some lovely podcasts, interviews with my friends and colleagues in the Moxie and My Medicine podcast, and then some other projects that are upcoming. And certainly we invite you to email me or to come visit us at our fabulous campus in Torrance, California. And of course, thank you. I am grateful that you have made it through the content today, and I hope you've enjoyed it.